Dear colleagues, ladies and gentlemen, Hein and Paulus, it's my pleasure to give a different talk in comparison to all the remaining talks during the day, because what I want to do, and that's my task, is to talk about something we do not know. And that is actually something which this group of authors did for the first time, because we thought that it might be of interest actually to discuss issues we do not know. Because usually we start discussing about different mechanisms, what we know, how to handle different scientific results. However, we thought that it might be very stimulative for the community really to define at least high priority gaps, which actually might be useful for scientists or also for industry, really to stimulate research and to come up with new trials and new ideas how to solve these issues. So, and for that reason, we, more than a year ago, actually, we started to work on this paper. It's called a white paper because we started with clearly just a sheet of paper with anything on it. And for that reason, we started writing this whole thing. And this is a list of the authors, and it was supported, of course, by the EHRA Scientific Document Committee. And we tried to come up, of course, with the gaps identified by the authors. I'm pretty sure if you go through the document, you will have probably new ideas. But that is exactly the purpose of this paper, because it should stimulate to think on different ways and to think about new ideas to stimulate research in arrhythmia. And I think this is helpful. So with regard to the paper, of course, we thought initially we focus on atrial fibrillation only, but then the decision was made really to broaden it up, also to go for ventricular arrhythmia and sudden death, as well as heart failure. And we thought that this is very helpful for the first paper to have a broader spectrum included. However, for this meeting, of course, I will just give you some highlights what our knowledge gaps are with regard to atrial fibrillation. So the paper, and I just approved the very final proof of this paper this morning, I think will be available online in the next couple of days or so. So you may have a chance to read the whole thing. It's a large document with more than 17 tables and a total of 17,000 words. So it's a very lengthy one. But I think it might be worth it, at least if you just look up for specific details or specific aspects included. So we were, or had the privilege that John Kem and Hein Heidbüchel provided the introduction of this paper. And I think it's important, of course, that this is something new for EHRA, but we think that this could be at least the first paper of its kind, and that many other papers might follow in this regard, and to help the community also to find arguments why specific questions are important. For that reason, of course, we have listed unanswered questions, but the list is far from complete, of course. So we started with regard to atrial fibrillation with different subsections. So we had something included about pathophysiology and screening, pharmacological therapies, rate control versus rhythm control, stroke prevention, of course, catheter ablation, device therapy, and also atrial fibrillation and orphan diseases. So I think this just provides a spectrum where the group of authors had to focus on, and we try to include components published previously, like the consensus paper on atrial cardiomyopathies with the different aspects of pathologic alterations, for example, also the paper on catheter ablation of atrial fibrillation and so on. So this is one example how the tables included in the paper look like for pathophysiology. So actually we try to find if there are case reports or number of case reports, if there is limited knowledge available with regard to registries or smaller trials which are not adequately powered. And then we thought it might be useful to say, well, do we think that resolution of this gap is possible or feasible? And if there are at least some trials going in this direction, they should also be listed in all the different tables. So you can see here that with regard to pathophysiology, and I don't want to read through all the different contents of the table, but you can see that, for example, targeting specific molecular mechanisms, of course, everybody would agree that this is a major gap, and we have to see how we can really solve this with regard to clinical expertise and with regard to clinical trials, of course. And if we continue gaps for screening, of course, there are many trials, and this is important because industry, of course, is also involved in this, and we will have trials from different studies like NOAA AFNET trial dealing with the problem of high-rate atrial episodes and occurrence of stroke, for example. But I think we need this information really to have a more full picture with regard to adequate therapy of atrial fibrillation. So what about, and this now becomes quite small, and I'm pretty sure that Stefan Hohenloser will also go through this in his talk later on with regard to pharmacological therapies. We do know that pharmacological therapy of atrial fibrillation is limited, of course, due to the number of drugs available. It might be possible that there will be new drugs or other drug targets. However, easy things like duration of therapeutic approaches, how long we have to treat before cardioversion, after cardioversion, for example, with a specific antiarrhythmic drug, or how we should use a combination of drugs, etc. So there are many components not really adequately addressed right now, and some of them are listed, and you can see that many of these issues here, that there are no randomized controlled trials available. However, the group thought that, of course, it might be feasible to do so and to come up with a trial to examine pharmacological therapy. And even more complex, the aspect of anticoagulation. And of course, we do have, especially after the introduction of NOACs, several trials with several compounds. However, we still think that many questions are unanswered. For example, atrial tachycardia, is it important to anticoagulate these patients, or atrial flutter, or how to handle patients after a long period of sinus rhythm, after successful catheter ablation, do they need long-term anticoagulation, and so on. And all these informations are listed here with also some trials which are still ongoing and where we have to expect the results. And again, this is also with regard to catheter ablation, where of course we do know with the new technologies, we see that many issues are solved. However, we still have many unsolved issues, especially substrate-based ablations interventions, where we have to focus on specific substrates, which of course varies with regard to the specific patient undergoing a catheter ablation approach, because we do think, of course, that the substrate is not the same in everybody, and we have to see how this may stimulate further research. And of course, in the section of catheter ablation, we have also included not only pulmonary vein isolation ablation technologies, but also AV nodal ablation, because with his bundle pacing, etc., also such ablation technologies might be of interest for the community as a therapeutic approach in patients due to specific clinical aspects. And this is also listed here, where we have the knowledge in device therapy, of course. Also, the question is how to use devices. Do we need new devices? What actually is the outcome of probably the diagnostic results of like samples like coming from the iWatch also? And for that reason, of course, we need to have solid data how to handle these information, because actually I think, especially with this digital approach to assess the patient's conditions, we also will find patients which are completely asymptomatic, and we have to characterize them a bit in more detail. So, and finally, this is one of the last tables in that paper dealing with assist devices and heart failure, where also we have to assess also in these specific issues how to handle atrial fibrillation in patients with a ventricular assist device. Does it imply more or increased risk of stroke, for example? How to handle these patients, especially after the CASTLE-AF trial. I think the interaction of congestive heart failure with atrial fibrillation is quite important, but also diastolic heart failure, where we still have to get a lot of information, and this is again also listed here. So I do know that this is a lot of information, but you may have a chance really to upload the paper, I think, in 1 or 2 days. And we think, and this is the final slide, and I think this is a very wise statement made here by Hein and John, that actually it should really be felt that this paper should stimulate research and it should stimulate discussion about the paper, because it's definitely not complete. There are many more gaps. However, we had to start from somewhere, and this is how we think we should work further on. And especially like a conference, or in a conference like this one, I think this is exactly the right spot where we can discuss also open and frankly gaps where we do not have any information, where we need a consensus. And for that reason, I think this is probably also the fact that I have to go first this morning. Thank you.